Alrighty, so today we're going to be talking about atherosclerosis. So let's break down that word. Athero is very specific. It means the abnormal accumulation of plaque in the walls of an artery, whereas sclerosis is a stiffening of tissue. So you put that together, and basically you have a plaque buildup in the walls of your artery that's causing a stiffening of the tissue. So let's take a look at a healthy artery to see what's going on. So you have your lumen, that's where the blood's going through, and then you have your arterial walls here. I've only drawn one side of it, that's all we really need for this presentation. But it starts with your endothelial cell layer. You can see there's little gaps because that's just how it actually is. You've got your tunica intima. You have your tunica media, which is filled with smooth muscle, which allows your arteries to contract or dilate as they need to. And then you have your tunica externa. And this is filled with vasoviscorum, which are actually, they're vessels which are going to provide oxygen perfusion to the rest of the artery to make sure it lives. So you've got these, and it's just supplying this whole thing with oxygen so that your arterial wall itself doesn't die. So let's start talking about atherosclerosis. What's going on there? First thing we can talk about is the risk factors. And I find it easy to think of the risk factors in two different categories. So you have risk factors that are going to increase your LDL. Now, LDL is low density lipoproteins, so like it's a form of cholesterol. And then you have risk factors that are going to increase free radicals in your bloodstream, which we'll get into in a sec here. So things that are going to increase LDL are things like living a sedentary lifestyle, being obese, eating a lot of junk food, just anything that's going to cause a cholesterol buildup in you. Now, things like smoking, diabetes, and hypertension are, well, smoking and diabetes are going to create free radicals, which are just like loose oxygen molecules. And what they can do is actually pull electrons off of the endothelial lining and weaken that layer. Hypertension, it's just going to cause a lot more pressure in here that's going to weaken this layer. So basically anything that damages your endothelial layer can be a risk factor for this. So let's say you're obese, you have some extra LDLs floating around in here, and you're a smoker too, okay? So over time, these free radicals are going to start attacking your endothelial wall here, and they're going to start to strip bits of it away. Now, usually it has those small small gaps, so it can facilitate like fluid exchange, stuff like that. But you're going to start to see gaps big enough that these LDLs floating through your bloodstream are going to be able to get through. So now you have some LDLs inside your tunica intima. Not a big deal, right? Your body can deal with this. So what your body's going to do is your endothelial cells are going to release their own reactive oxygen species that are going to immobilize the LDLs. Now, this actually isn't very great for you in this situation because it's going to hold these LDLs in place, and basically they're just going to live there in the wall of your tissue now. So the problem's still there. You still have LDLs in the wall of your tissue. So the next thing the body's going to do is you're going to get on the outside of your endothelial cells, or on the inside in the lumen, you're going to get these adhesion molecules. And what they're going to do is they're going to pull macrophages, which are a type of white blood cell. They're going to take those and pull them into here, right into the tunica intima. Those were monocytes. And once they go in, they're going to turn into macrophages. Now, what macrophages are going to do is they're going to eat all of these LDLs. But the thing is, they're not going to be able to get out either, okay? So now you just have these macrophages that have ate these LDLs, and they're going to turn into what's called foam cells. So you have these big foam cells, and as you can see, we're just getting more and more stuff build up in this layer here. So you've got these foam cells, and what the foam cells are going to do is they're going to release growth hormone. Now, the problem with this is that growth factor And the problem with this is that the growth factor is going to start taking some smooth muscle cells out of your tunica media and pulling them into here. So we're kind of running out of space. So what are we going to do here? We're going to have to make this a little bigger. And because the pressure is greater in the lumen than it is out here, we're going to start to expand out that way. So now we have all of these smooth muscle cells, and these smooth muscle cells are actually going to generate more smooth muscle cells in here. They're going to start to proliferate and increase this problem even morefold, right? So this smooth muscle cell proliferation is going to have the added effect of causing collagen recruitment. Now you have collagen and elastin, which collagen is going to give your arteries strength, elastin is going to give them flexibility. Now, you're getting all this collagen, and it's making this area stronger, but you're going to be kind of out of whack. So, like with in terms of elastin, so this area is going to get very hard, and you're going to end up with this sort of gross, clot-like hard thing in here, okay? Now, eventually these foam cells, they're going to starve, they're going to die, they're going to release these LDLs back out into here. So now all they've basically done in this process is add more stuff in to make this clot even bigger. So the whole time, it's getting bigger and bigger. It keeps expanding outward, and eventually the pressure is going to become so great from it expanding outward, and we're also going to see the other layers expand outward to make up for this. This might go like this, this might go like this, and eventually it's going to be forced to start expanding inwards, right? So then we may see something like this. So now you have this giant clot. It's starting to actually decrease the lumen size. And the other thing to note is before we had a much smaller distance to go from the vasa vasorum down to the endothelial cells. And those endothelial cells are going to start to die if they're not perfused. So once it gets bad enough, the vasa vasorum isn't going to be able to perfuse these cells anymore, and you're actually going to see the endothelial layer here die, and it's going to turn into a scab, which we call a fibrous cap. So now, instead of these pretty little endothelial cells, you have this big, ugly scab on the inside of your arteries. By the way, if I can give you any life advice, don't get big, ugly scabs on the insides of your arteries. It's really bad for you. So, at this point, this is where it can break into a couple of different pathologies, depending on where it is. And we're going to be focusing on the heart here, right? Now, before I get into that, I just want to explain a couple other words associated with atherosclerosis. So you have arteriosclerosis, which is a bit more broad of a thing. It's when you have stiffening of the tissue in arteries, and you have arteriolosclerosis, which is where you're going to have stiffening of tissue in the arterioles. So atherosclerosis is a type of arteriosclerosis, just this specific one that I've been showing you. And sometimes you may hear those words used interchangeably, arteriosclerosis and atherosclerosis. Just kind of important to keep in mind that there can be differences in them. All right. So what's going to happen if this is forming in the heart? So let's draw a heart here. And the two pathologies that we're going to be talking about in reference to this are stable angina and unstable angina. Okay. So here is your heart. Now let's say your right coronary artery here coming up. Let's say you have a patient and they've had a stable angina in here for a while, okay? So they've had this decreased lumen size, and what that causes is they have less blood flow getting through. So if it's in the right coronary artery, that's sort of going to do the inferior, provide perfusion to the inferior part of the heart. So this patient say she's seen a cardiologist, because what will happen is every time she exercises, her chest starts to hurt and she doesn't understand why. So the doctor prescribes her nitro, which is a vasodilator, and she takes that when it starts to hurt, and it seems to make the problem better. So that would be indicative that this patient is suffering from a stable angina. So she's at this point, right? A stable angina is when this fibrous cap is still intact and covering this. If you were to have an unstable angina, that would mean that this cap breaks off, which is very likely to occur because, for one thing, it's not going to be as strong as your normal arterial wall. And the other thing is, because you have this decreased lumen size, you're going to get a lot more turbulence in the blood here. So the blood flow is going to start bouncing off of this, damaging it, and it can rip that off. Right now, though, we're talking about stable. So that hasn't ripped off yet. What happens is when she's at rest, because you actually don't need, like, your body has redundancy systems built in, and one of those is the size of these arteries. So you don't actually need this whole artery to provide blood for you if you're just sitting around doing nothing. So say this lady lives a pretty sedentary lifestyle. She sits at the computer a lot. Maybe she goes out and plays golf once a week. But what's going to happen is when she goes out and plays golf, her myocardial oxygen demand, so that is MVO2. I'm just going to write that down because that is an important term that we will be bringing back up. But her myocardial oxygen demand is going to increase. So she's working harder when she goes out and plays golf, and she needs more oxygen. So once you can actually get up to 70 or 80% of a lumen size occlusion, and you can still be fine at rest. But once you start to exert yourself, you're going to notice symptoms. So what's happening there is everything downward of this just isn't getting enough oxygen. So when she has a stable angina, if it starts to hurt and she goes and sits down, that's going to help because that's reducing her oxygen demand. And if she takes a spray of nitro, that's going to be a vasodilator. So it's going to make this lumen just a bit bigger. And that's going to allow more blood to get through, and it's going to be fine. That's not what's happening with her today, though. Today, she said she started to get the pain, and it didn't come on when she was, it didn't come on while she was golfing. She was just watching TV while this pain came on. She took her nitro. It didn't work. She's been resting, and it's not working. So that is going to lead us to believe that maybe this lady is suffering from an unstable angina. So this is broken off, and all of these ugly bits have now leaked out, and they are all blocking up this artery. So there we go. The artery is now occluded. So what's going to happen here? Well, first thing is now you have a full occlusion. Your myocardial oxygen demands are not being met. So everything south of here, it's going to start to look to anaerobic metabolism to provide energy. Problem with anaerobic metabolism, for one, is it can't work for very long. After a very short time, you're going to run out, deplete your resources, and you're going to need oxygen again to supply that tissue. The other problem is that it's going to release hydrogen ions and cell metabolites. And those are both kind of acidic, and it's going to start to cause damage to the cells around there, and it can start to cause irritation to nerve fibers. Now, when you get irritation to a nerve fiber instead of, say, tissue damage, especially in a weird place like the heart, your brain doesn't quite know what to make of it. It's not used to your heart just starting to hurt. So that's why you'll see what's called visceral pain with these patients. They may describe it as pressure, tightness, squeezing, burning, but if you ask them to point to the pain, they may have trouble with it. And they may not just have problems in their heart. It's pretty common to see heart attack patients with pain in their shoulders, arms, neck, or abdomen as well, because the brain is confused by this signal and it's not totally sure what's hurting. So you can get pain in areas that are working just fine. And the other thing that you can look out for is a decreased ability to reproduce pain. So if I get a cut on my arm, I can be like, wow, that hurts when I touch it. Yep, I touched it again, and that hurts. Well, because you're having this visceral pain, you can't really do anything to replicate it. It's a body system that you can't really, you don't really control in that sense, where you can just make it hurt, make it not hurt, stuff like that. All right, so we went through that. We went through the referred pain, which is the pain in areas where nothing's actually going wrong. And we're going to look at an acronym. And that referred pain is the first part of it. And this is going to be something that's going to come back to you, so pay attention. We are talking about REDS. So you have the radiation of pain, emesis, which means vomiting. You have diaphoresis, which means sweating. And you have shortness of breath, which means you just feel like you can't catch your breath. So, what's going to happen is you are... Sorry. What's going to happen is you're going to start to... this area south of the occlusion is going to start to become ischemic because it's not getting the oxygen it needs. It's going to start to actually die. And at the same time, you have chemoreceptors, which are sensing that this area isn't getting enough oxygen. So they're going to activate your sympathetic nervous response. And this is where you get your diaphoresis from. Your sympathetic nervous response, you may have heard of it as your fight or flight response. It's going to cause you to start sweating. It's going to say, we're not getting enough oxygen. So how about we try breathing harder? We try breathing deeper. We try increasing the heart rate to perfuse blood faster. That in turn is going to increase blood pressure. So you're going to start to see that in these patients. The problem is that's not going to help at all because no matter how much oxygen you intake, you're still not getting past this barrier. So that's just going to worsen and worsen. And as this ischemia starts to take hold and parts of the heart start to die, the heart is going to lose some of its contractility. And when the heart starts to lose its contractility, it can't pump as much blood with each pump. And that's going to activate your baroreceptors, which are going to look at that, say, hey, we don't have enough cardiac output. So what we're going to do is activate the sympathetic nervous response. So it's also going to be telling you to breathe deeper, breathe faster. It's going to try to increase heart rate. And the problem with all of this is that you're already starved for oxygen here, and now it's just making the rest of your body have a way bigger oxygen demand as well. So it kind of just speeds up this process and just makes everything a lot worse. And eventually, you'll see a patient like this go into what's called cardiogenic shock, where they don't have the oxygen demand, like they can't meet their oxygen demands, and their heart is just going to start to shut down. If this part becomes fully ischemic, it's not going to be contracting anymore, and at that point, you're going to see a huge loss of vitals. Their blood pressure is going to drop dramatically, their heart rate's going to go down, and their respiratory rate is probably going to slow because they just don't have the energy anymore to keep those things going. So I think that about covers atherosclerosis and a little bit of stable and unstable angina. How are we doing there, Catherine? Do you have any questions?
Yeah, I just have one question.
Yep.
Does this only affect the coronary arteries?
No. So that's a good question. That's probably something I should have covered. But this can happen anywhere over the body. And if you're having it in your coronary arteries, there's a good chance that you're having it other places because all the symptoms are very non-selective. If you're a smoker, you're going to get these free radicals everywhere. If you eat junk food all the time, you're going to have extra LDLs in all of your blood. So it can lead to a lot of things. If you get atherosclerosis in your brain, then that can lead to a block in there, and that can cause a stroke. You can get peripheral artery disease, which is where it happens in your arms, or a lot more commonly in your legs. And that can lead to things like sepsis. In really bad cases, it can lead to amputation because if it's an unstable angina, then it's just not going to get any blood past that point, and the tissue can start to become necrotic. All right. So, with all that in mind, how do you feel about doing a test on the subject matter?
I'm ready.
You're ready. Okay, perfect.
Should I put my camera?
Okay, share screen. Okay. So, I'm going to host this. And I talked to Dale. He said if you fail this test, they're revoking your acceptance to the program. So,
Noted.
Take it seriously. Well. He doesn't like to joke around. Okay. This is loading. And okay, there we go. So, let's see. Friendly nickname generator on. Everything is perfect. Okay. And you can see my screen just fine, right?
Yep. I'm just jumping in right now. I've used it before.
Perfect.
7. Oh, it won't let me pick my own nickname? Oh.
Okay.
It's just gonna. Okay.
Mute that. Wow, look at that. 100% class participation. I don't know what all my teachers are talking about. That was easy. Okay. First question. Which of these conditions is not often a result of atherosclerosis? There you go. So I should have mentioned when I was talking about stroke, thrombotic stroke is the one that's most likely to come about as a from atherosclerosis. It's a type of ischemic stroke. There also is an association between hemorrhagic strokes and atherosclerosis, but that one is less obvious. Oh, hey, we have amazing email in the lead. Congrats to whoever that is. So, question 2. An unstable angina occurs when a fibrous cap forms over an area altered by atherosclerosis. True or false? Right.
Yeah.
So we're going to see unstable angina when that fibrous cap ruptures.
Yeah. Got it. Look at that.
I mean, still in the lead.
I wonder who that is.
Do it. That's just a little, go get them. Which of the following is the main risk factor of atherosclerosis? Okay, this one I should have actually gone over. Increased LDL is the right answer. Okay. Basically, the biggest factor in atherosclerosis is LDL running through your bloodstream. Sorry, I forgot to touch on that in my presentation.
Well, doesn't obesity cause increased LDL?
It can, but that's one of the factors that can cause it. The actual increased LDL is the main factor. Okay. So case study. You are responding to a 45-year-old patient who complained of chest pain. He was shoveling the driveway when it started. You arrived 15 minutes later, and he has been resting and took a hit of his nitro and claims he feels fine now. What condition is this patient most likely suffering from?
Stable and right.
Perfect. And we're saying stable because with rest and a hit of his nitro, he recovered. Yes?
Yeah.
Perfect.
Oh, I have a 4 streak. I got a streak.
Atherosclerosis. True or false? Atherosclerosis is a specific type of arteriosclerosis, though the terms are often used interchangeably. True. Yeah, perfect. Okay. When blank blind to blank, they are changed into blank.